वीडियो ऑन करके बस ऐसे ही करना है, बोल देना है। फर्स्ट वाले से ऐसा करेंगे, उस हिसाब से करेंगे।
We are live, please.
Okay. Good evening, everyone. I am from Bharati Vidyapeeth Medical College and Hospital, Sangli. My topic is hypovitaminosis A, a nightmare for young eyes. So we know vitamin A is a fat-soluble vitamin. It is essential for night vision, maintaining normal glandular and epithelial function, normal body growth, offers good resistance to 1,000 retinal equivalents. When the daily requirements are not met, it causes vitamin A deficiency, leading to nutritional blindness. So, vitamin A deficiency is a major controllable public health and nutrition problem in India. Estimated 5.7% of children in India and in developed countries, commonly seen in infants with low birth weight. Badly affected states are Andhra Pradesh, Tamil Nadu, Karnataka, Bihar, and West Bengal. So, Wall's visual cycle is the cycle which is responsible for vision in the eyes. These factors of vitamin A deficiency are living in an endemic areas, low socioeconomic status, malnutrition, maternal malnutrition, zinc deficiency, coexisting measles or other respiratory or diarrheal illness. Etiopathogenesis, it can be either due to dietary deficiency of vitamin A or malabsorption of vitamin A from the gut, or either due to reduced storage of the vitamin A, like in liver diseases. Xerophthalmia. Actually, vitamin A deficiency can lead to systemic or ocular manifestation. Ocular manifestation of vitamin A is known as xerophthalmia. It affects conjunctiva, cornea, and occasionally retina. WHO classification includes XN, that is night blindness, X1A, conjunctival xerosis, X1B, phytoid spots. X2 is corneal xerosis, X3A is corneal ulceration, which includes less than 1/3 of cornea, X3B, that is corneal ulceration including greater than 1/3 of cornea, XS is corneal scarring, and XF is xerophthalmic fundus. Symptoms of vitamin A deficiency include night blindness, dryness of conjunctiva, liquefactive necrosis of cornea, and ulceration of cornea. Signs include conjunctival xerosis, which is dryness of conjunctiva, where conjunctiva becomes non-wettable. Second is phytoid spots. It is a triangular white space, white structure on the interpalpebral region. Third is xerophthalmia. Of xerophthalmia is the corneal xerosis, where cornea becomes dry and lusterless. Fourth stage is xerophthalmia, keratomalacia. Keratomalacia, here there is ulceration of cornea due to liquefactive necrosis, including less than 1/3 of corneal surface. Next is keratomalacia, including greater than 1/3 of corneal surface, where ulceration takes place in the greater than 1/3 of the corneal surface. Next is corneal scars. And last is xerophthalmic fundus. There is white raised lesions on the retina. Investigations include clinically assessed eye signs, biochemically determined concentration of retinol in the serum and plasma. Differential diagnosis include trachoma, dry eye, retinitis pigmentosus, and pinguicula. Treatment and prophylaxis. Prophylaxis we can give according to national immunization schedule. That is, first dose 1 lakh international unit at 9 months. Second dose 2 lakh international unit at 16 months, and then 1 dose every 6 months till 5 years of age. Treatment includes immediately upon diagnosis, we give 2 lakh international units orally. Next day, 2 lakh international units orally. Within 1 or 4 weeks, 2 lakh international units orally. Other considerations include children between 6 to 11 months of age or less than 8 kg should receive half the dose, that is 1 lakh international unit. Or we can give intramuscular injection of water miscible retinal palmitate given to the children with severe stomatitis who cannot swallow or with persistent vomiting. Control and prevention. Now we know that vitamin A deficiency is preventable and curable. So primary eye care which we can give is, it can be treated and prevented at grassroots level by locally trained primary health workers who are first in contact with the community. Their activities include health education, dietary advice, immunization, better hygiene, and sanitation. So, three main intervention strategies for prevention and control are short-term approach, medium-term approach, and long-term approach. Short-term approach, prophylactic vitamin A administration in the endemic areas. 1 lakh international unit for less than 1 year of infant and weighing less than 8 kg. 2 lakh international units for 1 to 6 years of children orally every 6 months. and 20,000 international units for pregnant and lactating mother at delivery or 1 month before. Medium-term approach includes food fortification with vitamin A like dalda and milk. Long-term approach includes promotion of adequate intake of food rich in vitamin A, that is eggs, carrots, broccoli, papaya, fish, etc. Related national programs are Vitamin A Prophylaxis Program, Vision 2020, National Program for Control of Blindness and Visual Impairment. So I would like to conclude my presentation. As we know, vitamin A is leading cause of deficiency is a leading cause of blindness in India, but it is major controllable public health and nutritional problem in India. So we can it can be controlled by if at a very low level by the primary healthcare workers, or we can say barefoot doctors, which will help us in creating the awareness, immunization, dietary advice, and awareness about the health and sanitation. Thank you.
Okay, Dr. Dhanashri,
Yes, ma'am.
it's a good presentation.
Thank
You have elaborated nicely. Switch on your video.
you.
Switch on your video.
Yes, ma'am.
Yes. What are the types of xerosis you know?
Corneal xerosis, conjunctival xerosis.
Types of xerosis. Corneal and conjunctival, okay. But what are the types of xerosis you know? You said as a differential diagnosis,
Yes.
trachoma and some other conditions you mentioned differential diagnosis. What are the conditions you mentioned there?
Trachoma, retinitis pigmentosa, fingerquilla, dry eye.
Yes, dry eye, ocular cicatricial pemphigoid. Have you heard the name?
Yes, ma'am.
Yes. Any difference between vitamin A deficiency xerosis and the xerosis due to other causes like trachoma or other conditions, dry eye conditions?
Ma'am, in trachoma, there is a discharge from the eye, but in vitamin A deficiency, we cannot see a characteristic discharge from the eye.
That is okay. That is about the other aspects. Okay, leave that. Now tell me, how will you approach to treatment of a baby 1 year old having xerosis? A baby has come with the parents have brought the baby 1 year old and having xerosis. So how will you approach the case? 1 year old having xerosis. Xerosis of cornea, suppose.
So, ma'am, we will give vitamin A, international units of vitamin A syrup that we can measure by a spoon. Inner circle and outer circle. Inner circle is of 1 lakh international unit and outer is of 2 lakh international unit. So we can guide the parents about the dosage of the vitamin A.
Anything else you want to do, which is more important than giving prophylaxis vitamin A or therapeutic vitamin A? Anything else you want to do? These type of patients having vitamin A deficiency, now you have to find out what is the cause of vitamin A deficiency. Why there is vitamin A deficiency? Commonly in these patients, usually they have some systemic complaints. So you have to investigate what are the systemic complaints of the patient and you need to treat that. Otherwise, if the patient is having diarrhea, you go on giving vitamin A, the baby will not be benefited, because if you don't treat diarrhea, there won't be any improvement in the intake or improvement in the condition of vitamin A status. Okay, so any systemic condition you have to treat simultaneously. And protein rich, usually they have, these children, they have also other deficiency and other like protein energy malnutrition, that is also there. So you have to treat the patient as a whole. So treat the systemic condition, treat vitamin A, and local treatment. What are the things you need to give? Ocular treatment?
ocular, we can give artificial tears because the eyes become dry.
Yes.
And,
So these, what are the problems with a dry eye? Which year? You are which year?
ma'am, now I'm in fourth year.
Huh?
Now I am in part 2.
Third year.
Yeah, part 2.
Part 2. Okay. Okay. Thank you.
Thank you.
Stop sharing your.
Hello. Good morning, ma'am. Good afternoon, ma'am.
Any other participants?
Hello. Good afternoon, ma'am.
Good afternoon.
Ma'am, I am unable to share my slide, ma'am.
This, any technical person can help her. What's your name?
Ma'am, Akshita Singh.
Akshita.
Yes, ma'am. I'm not getting how to do the sharing in phone.
Any technical person? Can anybody help her to share the screen?
I'm trying from half an hour, but I'm not getting that.
Actually, you need to, what I know is you need to open the your presentation in the desktop, then on the share screen, then click the
Ma'am, I have done that, but also then also
thing.
I'm not getting the desired result.
Then also you are not getting.
Oh, ma'am.
Any other participant is there? Can continue with that?
डेस्कटॉप पे ही करनी पड़ती है मैम भी करके देख नहीं पा रही
Entered people are there, no?
Ma'am,
Hello.
ma'am, can I show?
Hello.
Yes. Can you help to share the screen?
IT team. Chediotech.
Akshita.
Hello. Yes,
Hello.
ma'am. Sir, I'm unable to share my slide in this.
Just a minute. Sunil, are you there? Anyone from IT? Okay. Ma'am, have you joined from laptop or mobile?
Sir, I have joined from mobile.
Okay, so you have your presentation in your mobile?
Yes, sir. Yes, sir. I have
Okay.
that.
So there is one button like a share screen. Can you
Yes,
click
sir.
on that?
Yes, sir. I have clicked on that.
So you are not able to share the screen?
No, sir. I'm not able to share that screen. Sir, in documents I have clicked on, but then also I'm not getting that.
Okay. No, but initially before just join, you have shared the screen once, right?
No, sir. No, sir. I'm not getting that option only to share that.
Okay, you go again on the Zoom.
Yes, sir.
Okay.
Yes, sir.
So have you you go to the Zoom application? Okay. So now you will able to see the down there is a one green color button share.
Yes, sir. Yes,
Click on
sir.
that.
I have done that. Yes, sir.
You click on that.
Yes, sir.
Are you getting any option of sharing things on your screen?
Sir, yes, sir. I'm getting, but in that also I'm not getting what I want in that. And
But we are not able to see your screen. Otherwise, once you share your screen, we will immediately get whatever the things is on your screen. So, are you on a Zoom platform right now, or you have just?
Yes, sir. Sir, I am
Okay.
on Zoom only.
Okay. There is one, the middle, there is one button, share screen. So you
Yes,
click
sir.
on that.
Yes, sir.
Have you click on that?
Sir, I clicked that.
So what after clicking anything is you are getting anything? Yeah,
Sir,
yeah.
Microsoft.
Actually, she need to open the presentation in the desktop first, then
Just a
share.
sec. Are you on? Just a sec, Doctor. Are you on a Windows or Mac? Hello,
Hello.
Doctor. Are you on a Windows or MacBook?
Hello. Yes, sir.
Are you on a Windows or a MacBook?
Sir, I am on the phone right now.
You want to present from the phone?
Yes, sir.
iPhone or Android?
Sir, Android.
On the screen there is something called share, green button.
Yes, sir. I clicked on that.
Just click on that.
Yes, sir. I clicked there.
Again, you will be asked what to share. There is a option called screen. Just click on it.
Sir, where?
On the pop-up.
The pop-up. Microsoft OneDrive is written in that.
No,
sir.
there. Just scroll down. There is something called screen.
Screen. Yes, sir. I
Just
okay,
click on
sir.
it. You will be able to.
Yes. Sir, I clicked there. Hello. Hello. Sir,
Just select your screen. Just select your PowerPoint presentation.
sir, are you able to see that?
You have a stop share there. Again, you have to do the same and keep your mobile on horizontal.
Okay, sir.
Doctor, you need to first open your presentation, then do the screen sharing.
Yes. Yes.
And on the screen, just select your PowerPoint.
Sir, done? Yes. Hello.
I mean, we select the presentation. We are seeing your screen.
Sir, screen. Yes, sir. I selected that. Sir, are you seeing that? Sir, I have shared the slide.
Yeah, just rotate your screen.
Sir, done?
Perfect, perfect, perfect.
Okay, sir. Thank you, sir. Hello.
Yes, start your presentation.
Hello. 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 Sir, am I audible?
Yes, you are audible.
Okay. Good evening, everyone. I am Akshita Singh from Government Medical College, Jagdalpur, and the topic of my presentation is vitreous humor. Ma'am, vitreous humor, it is an inert, transparent, jelly-like structure that fills the posterior 4/5 that is about 80% of the cavity of the eyeball. It is hydrophilic gel-like structure composed of approximately 99% of water. The vitreous cavity is bounded anteriorly by the lens and ciliary body and posteriorly by the retina. Now the embryology of vitreous. Cells of the origin of the vitreous cell includes cells of the surface ectoderm, angle layers, cells of the neuroectoderm, mesodermal cells between the surface and the neuroectodermal at the anterior rim of the developing cup. Now the primary vitreous stage, the primary body begins its formation about the closure of the choroidal fissures. The primary vitreous appears at the time of the formation of optic curve. It is an fibrillated secretion of the retinal cells and fills in the vitreous space with the fretwork of the fine fibrils. It is a mixture of ectodermal and mesenchymal origin. Now formation of secondary vitreous. Secondary vitreous is an avascular structure that surrounds the primary vitreous. It is secreted by the neuroectoderm of optic curve. It starts from 2nd month and completes by 5th to 6th month, marked by appearance of orderly era of fine dense fibers. Now this is the structure showing us the vitreous cavity. In this we can see the collagen fibers, hyaluroid, glycosaminoglycans, and a canal of Clockert. Structures. The vitreous is divided into 3 structures, that is the hyaluroid layer, the cortical vitreous, and the medullary vitreous. Now the hyaluroid layer, it is not a very true membrane, but the outermost surface of the vitreous. It has structures of connective tissue and follows fibrils which runs parallel with surface. It has 2 surfaces, anterior hyaluroid surface and posterior hyaluroid membrane. The cortical vitreous, it is a peripheral zone approximately 100 micron in width. It is more condensed fibrily vitreous. It consists of 2 types of collagens, that is sodium hyaluronate molecules which provide elasticity and viscosity. Now the medullary vitreous, it forms the major part of the vitreous body, less fibrillary than cortical vitreous. The water silk appearance in the slit lamp can be examined in the medullary vitreous. Now we have various tracts in the vitreous that are the sheath-like condensation of the vitreous tissue radiating from the ciliary body to retina, gives onion-like skin arrangement of adult vitreous. Now in adults we can see the types of vitreous, that is tractus retrolentis, tractus coronarium, tractus medianus, and tractus prelentinensis. Now we have in this structure we can clearly see the retrorental tract, the coronary tract, median tract, preretinal tract, retrolental tract, intermediate zone, and the preretinal zone. Zones for vitreous space. We have retrolental space, anterior boundary, that is patellar fossa, intermediate space in which it is surrounded by anterior boundary is epiciliary portion of anterior hyaluroid membrane, medially that is tractus retrolentis, laterally that is tractus perilentis, and in the preretinal zone we are having medially tractus periretinalis and laterally retina. This is the structure of vitreous base in the posterior part of the eyeball. Thank you, ma'am.
Okay. Presentation is okay. Now you are Akshita.
Yes, ma'am.
Okay, now what is the importance of vitreous base? Switch on your video.
Yes, ma'am.
What is the importance of vitreous base?
Ma'am, around. Hello.
Yes.
Ma'am, the vitreous base, around the vitreous base, around the vitreous base, vitreous is attached strongest around that vitreous base, around that oroserrata part.
Yes. What is the importance? What is its clinical importance?
Ma'am, in putting the retrobulbar injections or during the peribulbar injections, we are landing that oroserata, and we are not damaging the vitreous base. So that is the importance about oroserata, because it is surrounding the oroserata part of the vitreous base is surrounding that.
What are the vitro-retinal adhesions? What are the places at which there are vitro-retinal adhesions?
Ma'am, around the optic curve, it could be there on the post-capsular surface, around the retrolental space, around the choroid surface in the posterior part.
What is the clinical importance of vitro-retinal adhesions?
Ma'am, floaters can be seen in that, or floaters can occur after the adhesion. So it can be misdiagnosed as cataract or any vitreous hemorrhage in that.
Floaters. Do you know any vitreous substitutes?
Vitreous substitute, ma'am, silicone oil can be there, or perfluorocarbon can be there. Yes, silicone oil and perfluorocarbon liquid can be there, and ma'am, in that we can also use the air or the physiological gases.
Okay, that is okay. We have any more participants?
Okay, ma'am.
Any other participant? No? Should we stop this session? Hall 6.
Are we done? Should I close this?
Hello. Not sure. Let us check with Samantha sir. Can you check with Samantha sir about this?
Is there anybody else to present?
That Samantha sir is can only
Okay.
tell us. ग्लो का जो ये है ना ग्लो का